This is an 81-year-old lady who has past medical history of ischemic heart disease, diabetes, hypertension, hyperlipidemia, CML, and thrombocytopenia. She was admitted in November this year for deranged liver function, and the CT abdomen and pelvis was done showing cirrhotic liver, and the entire pancreas is prominent for age. The pancreatic duct and CBD are non-dilated, however there is cirrhosis and ascites. There are suspicions of autoimmune pancreatitis, but the IgG4 results are pending. And these are the CT films of the patient.
Morning.
And this is the US film.
Okay.
And we are going to do contrast enhanced US for this patient today.
This is a 81-year-old female patient showing a bit of bulged pancreas and also showing liver cirrhosis and ascites on CT scan. To evaluate the pancreas and other areas, I already inserted EUS scope. The tip of EUS is, at the current moment, we are in the esophagus here. We can see the pulsating heart around here, heart and the aorta, and vertebra, other structures here. But this is a bit rotated. So to get the orientation, it would be better to rotate this one, aorta at 5 o'clock, and the vertebra at 6 o'clock, and heart at 12 o'clock. Then the anatomy will be very similar to CT scan. And now I am in the esophagus. If I push the scope into the stomach, then the heart will disappear, and we will reach to the aorta and the liver. This is heart area. There are several ways to trace pancreas and other organs. I know that Rapport is a big fan of arterial tracing, but so I think during this course, I think he will show the arterial tracing technique. I'm going to show you the endoscopy guided pancreas tracing and liver tracing. Can you also see the endoscopic image now? Endoscopic image, yeah. I push the scope into the stomach here. We can see the antrum, high body and the antrum down there. And if I go into the stomach, by touching the posterior side of mid-body or lower body, I'm touching it and suction out the gas and start to trace the organs. The posterior side of gastric wall, there is pancreas. So after touching it, and I slowly push the scope back into the esophageal area. And in the meantime, we can see liver, and also, can you see the liver here?
Yes.
Yeah. If I push a little bit back, I should go a bit further. Yeah, then we can see the pancreatic tissue around here. This area is pancreas, and this area is liver. So we have the orientation now. But I started with 7 cm range with a large window. I can see a lot of structures. But if I have some orientation to see the pancreas, I'm actually zoom in. I want to enlarge the screen and want to see the pancreas. So I'm going to focus on the pancreatic area here.
Dong-Wan,
yes.
For many institutions, they do have only linear system available. Does it make difference if you use that radio or linear?
Even for linear, but the anatomy is a bit different. But sequence of tracing is basically the same, because we are looking at the same stomach and the same pancreas. So if the tip is located in the same position, we are looking at the same structure, but the angle of scanning is different, 90 degree, there is 90 degree difference. We are looking at the pancreas here, and we can see some vascular structures. This is celiac axis, coming from aorta around this area, celiac, and the splenic artery goes like this, and this is common hepatic artery. So if I trace the splenic artery, we can go. This is splenic artery. Can you identify splenic artery here? Search. Yeah. This is splenic artery, and splenic artery, splenic vein, and we can see some calcification around the splenic artery. This patient actually, I think, have atherosclerotic changes. We can see some calcific density inside the splenic artery. And also, upon CT scan, there was calcification in celiac trunk too. So we can trace this splenic artery and the splenic vein here. And if we push a little bit further, then we can see the entire pancreas body here. And we can appreciate the main pancreatic duct.
This is the size comparing to her age. You think it's still too big for you?
The main pancreatic duct, I'm measuring the size of the main pancreatic duct now. This is 2.6 millimeter. I think with senile change, I think this is within normal range, considering her age is 81. And the parenchymal echogenicity of the pancreas looks quite normal. There is no lobular accentuation or hypoechogenic strength or main pancreatic duct dilation, stricture, or calcific density in the parenchyma or pancreatic stone. Nearly looks normal, but upon CT scan, the tail was a bit enlarged. So I'm going to trace the tail area. This is the body area, and if I try to trace the tail, I slowly rotate the scope. Because of interest of time, I already put the contrast enhanced mode. For contrast enhanced, I'm going to do contrast enhanced DUS because the pancreas tail you are looking at here on the left side of the screen is a bit enlarged, considering her age is 81. Generally, the pancreatic parenchyma shows a bit of atrophy at this age, but in this patient, the pancreas is a bit enlarged. So we wonder where there is any infiltrative process going on, such as autoimmune pancreatitis, or is it kind of normal variation? It's not clear. So to confirm that, I'm going to inject contrast of second generation.
We have our Sonoview ready.
Yes.
Can
This
we-
is second generation contrast agent. After injection, normal pancreas shows enhancement from 10 seconds after injection.
How long?
After injection, we need to see right side screen. Right screen shows harmonic imaging. Because we are using harmonic imaging for contrast enhanced EUS, the image quality is poorer than normal ultrasound imaging, but it is better to detect harmonic signals coming from microbubble. Sonoview is totally intravascular agent, so we can see the microvasculature of the pancreas or any kind of lesion. Normal pancreas shows well enhancement, diffuse enhancement, but pancreatic cancer does not show enhancement at all or poor enhancement. On the other hand, neuroendocrine tumor shows very strong enhancement, so we can identify whether there is any lesion in this bulged pancreas.
So contrast is just injected, James.
Okay.
So how soon should we see some enhancement?
Now it's 10 seconds. We are looking at the right side of the screen. There is diffuse enhancement of the pancreas parenchyma. Can you appreciate it?
Yes,
This
it's brightening up.
Normal pancreas, I think a normal pancreatic enhancement. It usually lasts until 25 seconds. Now it starts to show washout. It's fading out. The enhancement is fading out now. But down here is we can see splenic vein. Inside the splenic vein, we can see a lot of microbubbles, contrast signals there. But pancreatic parenchyma is actually fading away. If there is any focal lesion or infiltrative process,
So your suggestion is it's better for focal lesion to identify a small vascularized tumor like PNET, something like that.
Yes, PNET, yeah, definitely. For neuroendocrine tumor, the enhancement pattern is quite different. It shows very early, strong enhancement.
What about pancreatic cancer?
Cancer does not show
and the
enhancement.
chronic pancreatitis.
Compared to normal pancreas, pancreatic cancer shows very poor enhancement or non-enhancement at all. Chronic pancreatitis in between, but there is lobular pattern. So the enhancement pattern is a little different from normal pancreatic parenchyma. I think in this case we are looking at the pancreas tail area here, but I cannot appreciate any kind of focal lesion. And if we go to the body portion, then we can see splenic artery showing very strong signal on the right side of the screen. But in the pancreatic parenchyma, I don't appreciate any focal lesion here.
For autoimmune pancreatitis, apart from sausage-shaped pancreatic tail like this, do you expect to see any special feature from US?
It a bit similar to the chronic pancreatitis, but autoimmune pancreatitis also shows a bit of enhancement. But there is some kind of lobulation, not homogeneous enhance. So there is a little bit of difference between normal pancreas and autoimmune pancreas. Autoimmune pancreatitis. Now it's already 2 minutes, around 3 minutes past, but we cannot appreciate any lesion here. So I don't think we need to do any kind of further study, such as biopsy, or in this case, these patients have liver cirrhosis, so they attempted FNA before, but there was bleeding, so they stopped it. And
yeah, we should wait for IgG4 level to
yes,
come back.
IgG4. The total IgG is a bit elevated, but in this pancreas,
Dong-Wan,
yes.
what is your final diagnosis here?
For me, the pancreas is a bit normal variation.
Okay, terrific.
Yeah.
Okay, we will leave you. We'll go back quickly to the bleeding room, I think.